Hello, I'm Dr. Asif. You all know me about my tutorial videos about the surgical lectures. So, as the continuations of previous video, you have seen that there is surgical instruments, which is very important for the exam purpose. Now, the another important things is surgical imaging. That means it has X-ray, MRCP, CT scan, MRI, and also MRCP. So there are some common investigations which we do every day to day life in case of different patients for diagnosis of different diseases. Sometimes some imaging are gold standard for diagnosis, say, particular cases. So let's have some beginning knowledge and also some knowledge sharing here in the surgical imaging lecture. Let's start. Firstly, I will discuss about the X-ray. So most common X-ray is the chest X-ray, okay, which is invariably asked in the exam. Here you can see there is a X-ray which consists of chest and the part of the abdomen, right? So before describing X-ray, you must know what is the reason of this X-ray. Okay, so when this is the film, so center portion of the film, that means if this is the film, the center portion of the film detects which region. In this case, this is the chest and part of the abdomen. So if this is the center of the film, in that case it detects not only chest but also the part of the abdomen. Okay, so how you will describe first. Your teacher will give you this X-ray and will ask, please read this X-ray and tell your findings. This is the first question. So this is the plain X-ray of the chest and part of the abdomen, showing there is crescentic gas shadow under the right dome of the diaphragm, and also fundic gas present in the under the left dome of the diaphragm, and there is no other findings here. And we can see some radio opaque and radiolucent shadows. That is, radio opaque shadows consist of the heart and the viscera, and the radiolucent shadows, that means the black shadows, consist of lung, and there's some other bronchovascular margin here, and radio opaque shadow also the bones also. Okay, so the most findings here is the crescentic gas shadow under the right dome of the diaphragm. Okay, so here the plain X-ray of chest. This is the PA view. Yes, in which view you need to know, because in case of chest, in case of adult we use PA view, but in case of children we use AP view, right? Okay, so this is the erect posture, that means standing positions with both dome of the diaphragm showing crescentic gas under the right dome of the diaphragm. So what is your X-ray? This is the perforation of gas containing hollow viscous. That means there is a perforation in the gut. The perforation can be occurs in anywhere. Okay, so the most common perforation is duodenal perforation, which is a benign perforation, and the malignant perforation may actually happen in the stomach. Okay, so what may be the pneumoperineum? What may be the possibilities of pneumoperineum? That is a perforation of gas containing hollow viscous, and during the laparotomy, during laparoscopy, carbon dioxide inflation. Yes, during laparoscopy we used to make a port and do some carbon dioxide inserted into the abdomen, and that causes abdominal distension so that we can see inside it. So we the surgeons usually use carbon dioxide, which is one kind of gas. So after the operation, if a paid person do X-ray, he can see some gas in the abdomen, which is not pathological. Another is a penetrating injury, that is stab injury, and the tubal insufflation test. Okay, so the clinical features. So what in this case, patient might have some sign and symptoms, and symptoms will be abdominal pain, and the sign will be generalized shock. If I, as a doctor, if I go for examinations, in that case, in case of inspection, thoracic respiration will be happen, board like rigidity, and the percussion, loss of upper border of the liver dullness. So if I go liver dullness from the second intercostal space, so it will be uh, absent, loss of upper border of the liver dullness, because liver is already um, in the gas. So direct contact of the liver with the costal wall or abdominal wall will not be happening in that case. That's why we will not feel that vibration under our finger, right? Okay. So, and the auscultation, so bowel sound will be absent because abdomen, so there is the gas in the peritoneum. That's why we cannot hear bowel sound, because air is a very um, low sound conductivity. The most increased conductivity is in the water. So sound can be passed through water and it can be filled so good. But in case of air, it is diminished. Okay, let's try for next one. Okay, so this is the X-ray of the abdomen, right? Because the center portion of the X-ray detects the abdominal portion. Okay, so this is AP view. Okay, in case of abdomen, in adult is AP view. So this is the plain X-ray of abdomen in erect posture. It is standing conditions. Anterior posterior view showing distending loop of bowel. Here you can see this bowel is distended in the central area of the abdomen with multiple air fluid line. Here this is the air fluid line, this is the air, this is the fluid. So multiple air fluid line present in the area with valvuli conniventis. Here you can see here the whitish line in between air sac, ray like longitudinal whitish line. These are the valvuli conniventis, and we can see this pattern is like a step ladder pattern, like step ladder. So radiologically, what is the diagnosis? This is the patient of small bowel obstruction. Okay, so what is the important cause of this? Why it occurs? Because from the textbook we know the bowel obstruction or gut obstruction has two major type, that is dynamic and adynamic. So dynamic obstruction means there is some mechanical blockage that could be intraluminal problem or extraluminal problem, right? So or in between the lumen. So if this is the luminal, so luminal maybe there may be a stone which can occlude the gut diameter, maybe impacted feces or hard stool, trichobezoars, that is hair ball, or the phytobezoar, the vegetable ball, and intramural, that means in the wall defect. So in the wall means pathological, that may be stricture, that may be TB, tuberculosis, maybe malignancy, okay, or a repeated fibrosis after infection. And extraluminal means band and adhesion, maybe band and adhesion attached with the gut wall and the abdominal wall, or the two viscera in between two serosal layer, there is an adhesion. Okay, so band and adhesion of herniated loop And also in case of adynamic, that means there is no mechanical obstruction, but there is some systemic electrolyte deficiency or some systemic problem, like post-operative period, like hypokalemia that causes paralytic ileus, or sometimes sodium potassium deficient. Also there's some any inflammation inside the abdomen that causes momentum adhesion uh, um, for a temporary purpose to prevent spread of infection. Okay, so mention three causes of young adult. That means if I can say this is a young patient, so what may be the causes that can happen here? That may be obstructed hernia, most common, intussusception, which is common in children, but in case of adult there may be a pathology. Okay, and intestinal TB or tuberculosis. So cardinal features of obstruction, it is very common. We all know that abdominal pain, vomiting, distension, and constipation. And the cardinal features of this patient already done. Examination findings. What will I examine in this case? So inspection, abdomen will be distended, and peristalsis may be visible. In palpation, abdomen is tender, rigid, and in case of percussion, if I may do percussion here or to hear something, so nothing specific, there will be no specific sound. Auscultation, early bowel sound loud, because our gut nature is he try to propel the obstructed portion to the distal part, but so initially the bowel sound will be loud, but when it is failed, when bowel cannot be moved, in that case bowel sound will be diminished or absent. And what are the investigations you will perform? In case of this, most common, cheap, available test is ultrasonogram of the whole abdomen. Then we will try to find out there is any large viscera inflammation or not, like pancreas. So we need to exclude the patient might have pancreatitis. So we will go for serum lipase or amylase, and then serum electrolyte. So it detects patient might have hypokalemia, hyponatremia, or other micronutrient deficiencies. Sometimes serum urea, creatinine, because of patient might have AKI, and some routine tests like CBC, the routine random blood sugar, complete blood count, hemoglobin percentage, chest X-ray, ECG for fitness, for GA, because patient has obstructions. So 40 to 60% patient recovered spontaneously by conservative management, but 40%, 30 to 40% people need surgery. So that patient may not be fit for surgery initially, but simultaneously we must make the patient fit for surgery, because sometimes surgery is life-saving or emergency. Okay, so electrolyte imbalance, I already told that hypovolemia may be done, hypovolemic shock, hyponatremia, hypokalemia, hypochloremia. So what will be the conservative management? So most of the patients will be recovered by the conservative management, like NPO, IV fluid, analgesics, antibiotic, catheterization, NG suctions, and the bowel preparation for and gut clearance. Okay, so proximal, in case of obstruction, proximal gut will be dilated, and a lot of infected and half rotten food materials will be stuck in the proximal portion. So that portion have some bacteria inoculations. For after that, it will make more toxic chemical materials. So we need to remove it by gut preparation as soon as possible. And the after resuscitations, some patient might need laparotomy and reduction and relief of obstruction by surgery, and the check viability of the gut. Sometimes some gut will be dead, or due to vascular occlusion, due to any 360 degree or 270 degree rotations that causes volvulus, so blood supply will be impaired. In that case, we need to know the viability of the gut and also the fixations. Some gut will be derotated, so we must rotate it and fix it so that further rotation will not be happen. So another thing is fluid. So what kind of fluid we will use? That is Hartmann solution is the main fluid because it is electrolyte rich fluid, and if it is not available, then cholera. Never give DA or DNS. Why? Because DA causes hyponatremia, dilutional hyponatremia, and DNS may causes hyponatremia along with metabolic acidosis. Okay. So this is another one. You can see this is the central portion of the X-ray is the abdomen. So this is a plain X-ray of the abdominal posture. Anteroposterior view showing there is a huge dilated portion of the gut or tire-like shadow present in the central to periphery of the abdomen. So it is like coffee bean sign or omega sign. So two parallel air fluid level here, two parallel air fluid level. Please see here on the diaphragm. So it is running from left quadrant to right iliac fossa. It is a tire-like shadow, and you can see whitish septation here. So this septation means hastration. So this is nothing but a large gut obstruction due to sigmoid volvulus, because in case of volvulus the gut will be dilated, because here is it is a closed loop syndrome. It is a closed loop, so the content in this portion of the gut is not going anywhere, not proximal, not distal. It is stuck here. So bacterial inoculations and fluid sequestration and also the toxic material will be formed in this loop. So this loop must be removed. Okay. So predisposing factor, what are the causes? That's why this condition may be happen. Firstly, old age. The patients of old age, they have limited power of peristalsis. Okay, so some old elderly patient are complaining nowadays about constipations and also complaining about diarrhea. So the long pelvic mesocolon, short attachment of long pelvic mesocolon, short attachment of pelvic mesocolon, increased mobility of the sigmoid colon, and high residual diet like fast food, like low fiber diet. These are the high residual diet, and overloaded colon, a huge meal, so and tightly packed meal can causes long-term overloaded sigmoid colon, and also the chronic constipation in case of elder patient. And the clinical features, what will be same like distension, like constipation, like pain. These are cardinal features, and like mass in the left abdomen. So further other investigations like this thing, like ultrasound of the whole abdomen, serum urea, creatinine, echo ECG for fitness, and the serum electrolyte, serum amylase, and lipase. Okay, so treatment same as conservative management, then laparotomy followed by fixation of the sigmoid part, that is sigmoidopexy. Before laparotomy, pass a flatus tube to release the gas and pressure. This may be relieve obstruction and volvulus spontaneously. Why? Because we need to push a rubber tube through the anus to derotate it, try to derotate it, and it can causes release of some stool, the stuck materials. Sometimes patient will be relieved, obstruction will be relieved, but it is temporary, so we must do laparotomy and fix the colon in the abdomen, right? Okay, so this, what are the options here? Sigmoidopexy, if not possible, in that case dissection and anastomosis, and placement of the stoma, that is in colostomy. It is called the Hardman procedure, or sometimes both end, proximal and distant end of the gut will become outside for temporary time period. This is called Paul Mikulicz procedure. So life-threatening complication if the treatment is delayed. Okay, if patient comes delayed or the patient come after the golden period of time, in that case patient might have strangulations already, obstruction to strangulation, then gangrene, then perforation, then peritonitis, followed by and the septicemia, also the septic shock and death. Okay, so these are the things which is very important. You need to continue the answer like this, like strangulation, gangrene, perforation, peritonitis, and after that septicemia. Okay, this is X-ray of the abdomen, also part of the pelvis and bladder and kidney. So this is the KUB X-ray. Okay, this explains the KUB region in erect posture, same, showing radio-opaque shadow in the right lumbar region. Here you can see the radio-opaque shadow, rounded oval radio-opaque shadow in the lumbar region, just aside L1, 2, 3, in between 2 and 3, or along the third lumbar vertebra. And in case of left side, you can see another 3 shadows of the same region. Okay, so this is the patient of right-sided and bilateral renal stone. So what are the further investigations? One is IVU and USG of the IVU means intravenous urogram, and USG of the KUB, and serum creatinine and urea, because we need to know the kidney functions. So in that case, RFT or renal function test is necessary if we see there is a evidence of failure, like edema in the leg. Okay, patient is dehydrated and BP is high, anemic. In that case, we will go for RFT. It is renal function test. Okay, one minimally invasive, one non-surgical. So non-surgical procedural extracorporeal shockwave lithotripsy. So we will give shockwave from outside and destroy or make the blood stone into small pieces, and then it will be spontaneously relieved by a Dormia basket or any grasper forceps. And minimal invasive procedure may be percutaneous nephrolithotomy, that is PCNL, because you will make a small incision here and you will go through the pelvis and renal and kidney, and you will take the stone and close it. And one surgical procedure, one nephrolithotomy, if the stone is more enlarged or stacked in the whole kidney, like staghorn calculi, and like a huge enlarged stone, and the kidney function is reduced, in that case we will go for open nephrolithotomy and open pyelolithotomy in the renal pelvis. Okay, open procedure. Okay, sorry for inconvenience. Acha. Then you can see open procedure. So what are the surgical complications during this operation? Hemorrhage, because kidney is a highly vascular organ, and about 93%, not 93, 25%, yes, total 25% of total cardiac output go through the kidney. That's why hemorrhage is a very common complications. So injury to the kidney renal tissues, injury to the ureter, injury to the gut and vessels, and infection, pyelonephritis, septicemia, septic shock, failure of the stone removal, because sometimes we go through the region but we cannot find stone in time. In that case, thus failure of the stone removal and failure of complete removal of the retained stone. Sometimes stone, a fragment of the stone can be retained through the kidney. And the complication if left untreated, if a patient stayed like this, what will be the complications? Like hydronephrosis, pyonephrosis, damage to kidney, acute tubular necrosis, and infection and septicemia and septic shock. Okay, so hydronephrosis means the water will be backflowed and the kidney become enlarged. Pyonephrosis, the pelvis has the same pressure effect, so pelvic become dilated, and so due to the backflow, the kidney normal kidney function or nephron function will be deteriorated. Necrosis or sometimes infection, septicemia, and shock, and patient may die after a uh, prolonged repeated infection and repeated uh, failure. In that case, patient's kidney will be damaged. Okay, so this is the another common X-ray, like pneumothorax. Here you can see this the X-ray of the chest in posterior anterior view, showing the lung field is elongated here because this is a patient of COPD, a barrel shaped chest. Okay, and you can see some common findings. That means here the radiolucency of the left side is more than right side. So, and here is the absence of bronchovascular margin. So here is no bronchovascular margin and hypertranslucency in comparison to the right side. So right side there is a lungs and it has bronchovascular margin, but there is no lung here, and lung is collapsed. So this is the lung only. You can see the lung is collapsed here. This is the lung. And the trachea is shifted to the opposite side. Okay, trachea is shifted to the opposite side. No bronchovascular margin. So this is the tension pneumothorax. So it is an emergency procedure. We will go for tube thoracostomy. Okay, to make this negativity become positive, so lungs become inflated, and patient will be saved. Okay, very common and very important. Here you can see the another contrast, that is contrast X-ray. So there is something is swallowed, and and after that we can see the stomach. Okay, the left side of the abdomen shows here it is the only one viscera which is called stomach. So what it is, this is the barium male X-ray of the stomach and duodenum. Identify this plate. So identifications. Okay, so barium male X-ray of the stomach and duodenum showing loss of duodenal cap. Here there is no duodenal lumen, so duodenal cap is lost. Contrast didn't pass through duodenum, so contrast didn't pass through duodenum. Symmetrical narrowing of the distal end of the stomach. Symmetrical narrowing. End of the stomach is a symmetrical narrowing. Okay, from both sides. And dilated proximal part, and proximal part is dilated, right? This is dilated part. This is the narrowed part. And the diagnosis gastric outlet obstruction, most probably due to the pyloric stenosis, because there is no filling defect, there is no irregularities, there is no growth protruding through the lumen, right? So the most commonly this is the benign pyloric stenosis. So what are the investigations we will perform? Like most commonly ultrasonogram of the whole abdomen, upper GI endoscopy, and the serum electrolyte and metabolic and electrolyte imbalance effect. So as the patient is not the patient's food is not passing to the intestine, so patient has no nutrition and electrolyte. So due to some deficiency of electrolyte, and there is a problem of nerve conduction, there is a problem of gut movement, there will be a problem in hypoglycemia because glucose is not absorbed in the stomach, only some protein, so fat and carbohydrate will be absent here, so and some electrolyte. That's why there will be a complex conditions and patients have vomiting tendencies because food is not passing. So where it will go? It will go proximally. Okay, so this is the conditions where hypokalemia, sodium loss, hyponatremia, hypochloremia, metabolic alkalosis, and paradoxical aciduria. Metabolic alkalosis means because stomach will produce some hydrochloric acid, and due to vomiting that hydrochloric acid will be washed out. So loss of proton. In that case, balance will not be maintained and metabolic alkalosis occurs. But paradoxical aciduria, where? Because in case of renal system, this condition will be compensated, try to compensate by the kidney. But so due to loss of acid, um, in comparison, kidney will try to what? Try to create more bicarbonate production to compensate the area. And due to more bicarbonate production and chloride condition, chloride reabsorption, the more proton will, or the hydrogen ion will be released through the kidney in exchange of sodium and potassium. That's why aciduria, paradoxical abnormal aciduria occurs. Okay, so resuscitation is done by normal saline or Hartmann solution is the best choice. It will correct hyponatremia and hypochloremia and give potassium through the dextrose normal saline or potassium in the normal saline. And rest will be corrected automatically. Okay. So correction of dehydration by fluid, correction of anemia, then NG suctions to prevent vomiting, and nutritional support given by parenteral nutritional support, like Cabiven or percutaneous jejunostomy. Sometimes if it is complete obstruction, in that case percutaneous gastroenterostomy or percutaneous feeding jejunostomy can be done. So definitive balloon dilatation and make the lumen more viable, vagotomy and gastrectomy followed by gastrojejunostomy or bypass. Okay, here gastric outlet obstruction due to carcinoma of the stomach. So here you can see this is the rounded area. This is the rounded, this is the stomach, right? And the end of the stomach is irregular and there is something here in here. Okay, and the portion is not complete obstruction, but the margin is not regular, right? So and the part of the dye is passed through the duodenum, but you can see this this duodenal end is irregular margin, and stomach is not so dilated. So this is the barium meal X-ray of the stomach, shows barium shadow in the esophagus here, barium meal stomach and duodenum also, and follow through the small gut. It follows through the small gut and barium enema of the large gut. Sometimes you can see. And one image that dye is used, IVU, T-tube cholangiogram, contrast in CT. Okay. This dye is used in the IVU, T-tube cholangiogram, and contrast in CT. So same dye can be used in different imaging tests. Okay. So this irregular filling defect, the distal end of the stomach. Here you can see the irregular filling defect. And dilated proximal portion of the stomach and contrast passed through the duodenum, right? So radiological diagnosis, gastric outlet obstruction due to carcinoma stomach. And how to confirm the diagnosis? Upper GI endoscopy followed by biopsy and histopathology. So upper GI endoscopy followed by biopsy and histopathology. This is the gold standard test, and we will take 8 to 10 different biopsies from different segments of the stomach, because stomach malignancy is scattered, like diffuse in nature. So in some reason, normal tissues might not be present. That's why 8 to 10 biopsies must be taken. So 5 relevant symptoms. What will be the symptoms? Like anemia, weight loss, anorexia, vomiting, and abdominal lump. And left sign will be varicose node, supraclavicular lymph node, cister Mary-Joseph's nodule, and a Plummer shelf. Plummer shelf in the rectum, and cister Mary-Joseph's nodule in the umbilicus. Because some stomach malignancy which already evade the serosal level, that spread through the falciparum ligament up to the umbilicus. So there will be a growth or pink strawberry colored or reddish colored nodule present in the umbilicus. So this is the system Mary-Joseph's nodule. So this is the very advanced features of malignancy. And the left supraclavicular lymph node enlargement. It is called the varicose node. Okay, this is the post-operative P-tube cholangiogram. You can see this is the X-ray of the abdomen, shows hepatobiliary channel is visible, and there is a tube goes through outside. So this is the T-tube cholangiogram, right? And this is clumped. This is a clumped T-tube cholangiogram. This is unclumped T-tube cholangiogram. Okay. So T-tube given after open cholecystectomy, because this is biliary exploration surgery, like choledocholicotomy or biliary stricture. In that case, we will go and open the bile duct and the release of the stone or stone removed, and then a T-tube inserted and the part of the T-tube is closed. Progressive clumping. So how many days? At least 7 to 10 days. The T-tube will be stayed in the as a drain, and in the 8th, 9th, and 10th days, progressive clumping. So like this is the clumping stage. This is the unclumping stage. So 11th day T-tube cholangiogram done, and if it is normal, if this segment is patterned, in that case we will remove the T-tube in the 12th day. So what will be the name of the radiograph? The T-tube cholangiogram, right? So finding will be T-tube is in position. What is the finding? The T-tube is in position. Extra and intrahepatic biliary channel. So this is the intrahepatic, this is the extrahepatic biliary channel visible, and diameter of the CBD is normal. No stone is seen inside the CBD. No filling defect, like this is normal. So here you can see some narrowed area. This is some filling defects, I think, here present, and dye is passed to the small gut. So this is small gut and dye already passed. Okay. So where this investigation is usually performed, that is cholecystectomy after operation, cholecystectomy with cholecystectomy T-tube drainage. This is the operation. And don't say cholelithiasis, no, cholecystectomy. So cholecystectomy is the treatment is cholecystectomy followed by cholecystectomy and T-tube insertion. This is the total term. So what is the next step? Since everything is normal, T-tube will be removed in 12 POD, post-operative day, gently by traction. Causes of radiolucent shadow in the biliary tree in post-operative tube cholangiography, radiolucent stone and air bubble, clot and worm bolus. Complications of T-tube: the tube itself may be blocked, and obstructive jaundice, and right upper quadrant pain, leakage of the bile, and the stricture, infection, clot formation in the CVT. So complications is one of the dangerous effect for T-tube management or this kind of operation. Like tube itself may be blocked, so it may be flushed out, and obstructive jaundice occurs due to the tube. leakage of the bile. So bile can be leakage from the where it is attached. From those side, bile can be leaked. Stricture, due to prolonged keeping of the tissue, there will be stricture can be happen due to cholangitis. Then clot formation, due to injury or bleeding, there will be a clot. Okay, these are the very common X-ray. So post-operative tissue cholangiogram also you have seen that. Now this is the IVU showing hydronephrosis, intravenous urography. So when we need to know the architecture of the renal system, not only kidney but also the ureter and excretory portion, we will perform intravenous urography, and some stone which can be visible through IVU. Like contrast X-ray of the kidney and urinary bladder region, intravenous urogram and IVU. On outline of right kidney is enlarged. Calyces of the right side is dilated. Calyces are dilated. Okay, and pelvis of the right kidney is dilated. This is the kidney right side, and the pelvis dilated, and also the calyceal system is dilated. So my diagnosis is right-sided hydronephrosis. Okay. So why will be the problem? The problem may be bladder and urethra. So outflow obstruction, and due to outflow obstruction, the pressure effect goes to the proximal portion, and the ureter and kidney and the pelvis will be dilated. That's why. So there are some 5 important causes of bilateral hydronephrosis. Very important. There is bladder stone, benign enlargement of prostate, prostatic carcinoma, bladder carcinoma. In case of urethra, urethral stone, stricture, cancer, and some ureterectomy can be done. So name of operation hydronephrosis. So what will be that? Because you have to relieve the obstruction. This is the main motto here. According to the cause, if treatable, pyeloplasty, nephrectomy. Yes, if long-standing hydronephrosis, in that case, the kidney is not viable, or kidney functions is deteriorated in case of long-standing hydronephrosis. So kidney must be removed. And here, most common cause of unilateral hydronephrosis is PUJ obstructions, pelvic junction obstruction. And treatment of this reconstruction of the pelvis, that is pyeloplasty. Sometimes pyeloplasty, remove the stone, and the pyeloplasty can be altered the situations there. Treatment of the most usual cause of bilateral hydronephrosis is a 50 years old male. Like, what will be the treatment? The treatment will be tamsulosin, yes, alpha blocker, and prostatectomy, that is TURP, TBT, RPP, PPA. This is it. So TURP is most common for BPH management. So 3 indications for surgical treatment of the renal stone. What are the 3 indications? Stone size, it should be large, and the recurrent attack of the stone here, but it may causes infection, or it may causes inflammation, pain, fever, hematuria, and also the infection of the kidney and pelvis, like pyelonephritis or evidence of pyelonephritis. It can causes intervention or surgery. And this is the renal stone in the X-ray, KUV, and IVU. Okay, so name of the imaging is contrast X-ray of kidney and urinary bladder. So which investigation is mandatory? Creatinine, because you can see a huge multiple stone in all through the kidney. So the renal function must be checked, because I think renal function is not left normal. And here, dye will pass through the kidney. That means kidney excretory function is good. But if we give dye, and the dye cannot pass through the kidney, in that case, the viability, like this side, you can see there is no dye is passed. All the dye pass through the left side, but in case of right side, there is no dye passed through from the kidney to the bladder. That's why viability is, I think, no more. So nephrectomy is needed. So what are the classical presentation? At a loin pain, hematuria, there may be fever. I already told you that. Three options: non-surgical, minimally invasive, and surgical. So non-surgical extracorporeal shock wave lithotripsy, minimally invasive percutaneous nephrolithotomy, and surgical nephrolithotomy or pyelolithotomy kidney. So now this is orthopedic X-ray, very common, that is supracondylar fracture. You can see the part of the humerus, part of the radius ulna, and the elbow joint. So the part of the lower part of the humerus is fractured and then displaced. This is the AP view and the lateral view, showing proximal part of the radius and ulnar dislocations, and humerus showing fracture. So fracture of the supracondylar region of the humerus, posterior displacement of the lateral view, and medial displacement of the AP view. Here the medial displacement, this is the anteroposterior displacement. Okay, so you need to mention the displacement in both X-ray, because it is the lateral view, it is the anteroposterior view. In anteroposterior view, medial displacement, and in case of lateral view, it is the anterior posterior displacement, this is the medial displacement. Okay, you must know what is the view of the X-ray and what is the exact findings. When does it commonly happen, or mechanical injury like fall from outstretched hand, road traffic accident, fall from height, disease. Age should be 5 to 10 years because mostly young adults and elderly age patients are fall due to some cerebral effect, due to stroke, due to road traffic accident. So and in case of young adult, this is a trauma or accident. So what you will see here, you see the deformity, bruising, and swelling, because here is a brachial artery or a median nerve here. So sometimes this structure may injured after the fracture. So sensations, deformity, and bruising, swelling, right? This is a brachial artery, so there may be a bruising or vascular viability issues, so it must be checked. Sensations, pulse, sensory examinations, because median nerve sometimes injured, that's why sensory examination is needed. And the temperature, tenderness, temperature, because the blood supply may be impaired because there is a brachial artery which may be ruptured, and the sensations because the median nerve, which is a large nerve, it must be, sometimes it is injured. And some motor movement, look, feel, and move. We'll do some 3 tests. Okay, so what are the injury, what are the complications? Hemorrhage, injury to the surrounding structures, infection, nerve injury, median, ulnar, and radial nerve vessels injury, brachial artery injury, compartment syndrome, most dangerous and most concern issue is compartment syndrome, and air embolism sometimes. And delayed, if the patient stayed with this, in that case there may be a delayed union, malunion, and non-union, joint stiffness, Volkmann ischemic contracture. Okay, and what type of deformity may occur due to nerve damage? Okay. Okay. Here you can see the fracture neck of the femur this time. So here, this is the X-ray of the pelvis, anteroposterior view, because the central portion is detected in the pelvic region, and the anteroposterior view including both hip and joint and proximal part of the femur. This is the hip joint and proximal part of the femur, showing disruption of the sentence line on the right side of the fracture line is seen in the neck of the right femur. What is the sentence line? This is the central line. This is the sentence line. Okay. here is the sentence line. So this is regular sentence line this side, but this side here the fracture, the head is fractured, so sentence line is disrupted here. Okay, and the right femur is displaced laterally and upwards, and the radiological diagnosis fracture neck of the right femur. So fracture neck of the right femur, and the common victim is postmenopausal ladies because they have osteoporosis. And the clinical presentation may be pain in the hip, unable to walk, and the right side of the lower limb is shortened, externally rotated, and the treatment is immediately is in shock, IV fluid, blood transfusions, patient mobilized in rest. And so what is the treatment? Management. If it's in shock, then IV fluid, blood transfusion, patient immobilizations and rest. And analgesics because patient has tremendous pain. And anti-ulcer. And definitively undisplaced, that is hip screw and plus immobilization. And if undisplaced, in that case, open reduction, internal fixations. And by the age of less than 20, then newless pain. If the age is less than 20, the newless pain is inserted. If more than 20, then dynamic hip screw. I think dynamic hip screw is more common because up to the 70 years, and after these 70 years, it is a hemiarthroplasty is uh, needed in case of elder patient, followed by immobilization and physiotherapy. So complication may be hemorrhage, injury to sound structure, infection, nerve injury, vessel injury, immobilization, ear, pulmonary, delayed avascular necrosis. First, you have to say that because it's very important and dangerous complications. That is avascular necrosis. Delayed union, malunion, non-union, joint stiffness, Volkmann ischemic contracture. So, if untreated, avascular necrosis of femoral head. It is the important things that your teacher try to know that if you say avian or not. Here you can see the fracture of the shaft of the femur. This is the shaft and partially displaced fracture of the lower limb. That means femur. So mention 3 findings. Plain X-ray of the left thigh including hip joint in AP view and lateral view. Fracture in the shaft of the femur. Distal fragment is displaced laterally in AP view and posteriorly in the lateral view, and distal fragment is displaced proximally. So you have to mention the whole findings like fracture in the shaft of the femur, distal fragment is displaced laterally. I already said that. And the radiological diagnosis fracture shaft of the femur. And they mention the clinical features, that is shock, then limb shortening. It is a very common findings. Swelling, hematoma, tender and restricted lymph movement. And treatment of this case, initial management will be shock, IV fluid transfusion, definitive, skeletal traction like audit, adult patient, skeletal traction for adult, and the surface traction for children. So skeletal traction and surface traction, both are two things. Skeletal traction done by external devices and brick, and the surface traction is just patient is hanging. Children is in hanging positions. That is surface tractions. And if there is a 6 years hip spike plaster and more than 6 years titanium elastic nail system, TENS. And in case of adult, plate, screw and nail. Okay. Just try to memorize this thing. There is a 6 hip spica, there is more than 6, then titanium elastic nail, and adult and elderly plate, screw, nail. And then immobilization of the 12 weeks in adult in the long leg cast, massive hemorrhage. What are the complications? Massive hemorrhage. Due to what? Due to a huge blood vessel goes through aside the this limb. That's why these vessels may be ruptured or may be injured. In that case, femoral artery may be injured, femoral nerve, sciatic nerve may be injured, delayed union malunion, which is the bone related complications, and the most immediate grave complication, hypovolemic shock. Here you can see the patellar fracture. One of the another important things in orthopedics X-ray. Here the patella is fractured into two segments. X-ray of the knee joint include patella, distal femur, proximal tibia and fibula showing fracture of the patella, and proximal fragment is pulled upward because proximal fragment is attached with the quadriceps femoris muscle. That's why it is pulling upwards. Neurological diagnosis and fracture of the patella, trauma, sudden violent pull of the patellar tendon, look, knee swelling, bruising, knee pain, crepitation, restricted knee joint movement. Treatment is undisplaced immobilization by plaster by 6 weeks, and if displaced, open reduction internal fixations, and by plate and screw nail, and plaster immobilization physiotherapy. Definitive surgical treatment is hemorrhage, injury to the surrounding structures, infection, nerve injury, vessel injury, immobilization of the air. Delayed union, malunion, non-union. Okay, so these are the as common as previous one. So try to remember this. Look, knee swelling, bruising, knee pain, crepitations, and restricted knee movements. And in case of treatment, immobilization for 6 weeks. If displaced, open reduction internal fixation by plate, screw nail, immobilization of physiotherapy. Okay. And you can see this is the tibial shaft fracture. Transverse fracture of the tibia shaft. Okay. This is anterior posterior view, this is the lateral view. The fracture shaft of the right tibia and the internal fixation plate, screw nail, and immobilization long leg cast. Internal fixation by plate and long leg cast is given up to the mid thigh to foot. Open reduction, skeletal traction. In case of children, surface traction, fixation, internal fixation plate, screw nail, immobilization long leg cast. And in upper limb, adult 6 weeks, children 3 weeks, and lower limb, adult 12 weeks, and children 6 weeks. Okay, just time period, because lower limb healed delayedly. In that case, upper limb 6 weeks enough, and 3 week children, and in the lower limb, adult 12 weeks and children 6 weeks. So in this case, adult 12 weeks, and if we go through only cast, in that case, healing will be much more delayed. Adult 12 weeks, 6 children 6 weeks. Clinical sign of healing is tenderness, unable to move the fracture. As already given, known things. Here is a bone tumor. Now the bone tumor can be diagnosed through X-ray. So in left side you can see giant cell tumor, and in the right side you can see osteosarcoma. So in case of giant cell tumor, you can see some bone loss here. Radiolucency developed in the bone, and this is septated, septation present, and multiple porous bony structures. So plain X-ray wrist joint here, distal radius and ulna also hand showing multiple osteolytic lesions. Soap bubble appearance, yes, this is the important term. Soap bubble appearance of the lesion, and widening of the distal radius. The distal radius is widening, and thinning of the cortex. Thinning, cortical region is thinned out. Cortical region is thinned out. Soap bubble appearance and widening of the distal radius. Okay. So giant cell tumor of the radius, and also it can be 3 possible diagnoses: osteoblastoma, osteochondroblastoma, GCT, or giant cell tumor, simple bone cyst, aneurysmal bone cyst. How will you confirm? Biopsy and histopathology. Outline the treatment plan. What will be the treatment outline? Wide local excisions, and medical therapy by biological therapy, denosumab, chemotherapy, radiotherapy. Okay. And here you can see the osteoproliferative growth or extension from the periosteum or the cortical region So in this case, mixed osteosclerotic lesion, sun ray appearance. Here is sun ray appearance and Codman's triangle. Here this is the triangular area. This is the triangle. The triangle and periosteal reactions and radiological diagnosis of osteosarcoma. And the two common sites, so lower end of the femur, upper end of the tibia, and upper end of the humerus and lower radius. That means metaphyseal region. And the clinical presentation in young, weight loss, cachexia, anemia, looks swelling and redness, and move restricted movements, and also maybe uh, pathological fractures, maybe absolute pathological fractures. So surgery followed by prosthetic chemotherapy and radiotherapy. So surgery and prosthesis, chemotherapy, radiotherapy. So these are the treatment plan, and treatment plan is not so good. It is poor prognosis. Another malignancies can be happen like Ewing's sarcoma. In case of young children, shaft of the long bone will be affected, and this prognosis is much more worse, like 3 to 6 months only. Now, these are the X-rays. These X-rays are common, and if you go through my videos again and again, I think it will give more reachable and more you can memorize, and you can understand the X-ray, what it gives us information and how it should be presented in front of your teachers. Okay, now the rest of the imaging part is MRCP, mammogram, and CT scan. Okay, sometimes there's some CT film, MRCP film, some report. They will give you the reports, and you have to make a report. Okay. So firstly, mammogram. You can see this is the mammography film. This is the breast mammography, and you can see some vascularity and some puckering whitish areas and some white lesions here. This is the lesions. This is the breast tissues. Okay. So here you can see some radio opaque shadows here, and radio opacity is more. So 40 years of old lady present with a suspected lump in her right breast, FNC relevant lobular carcinoma. Now imaging investigation. So mammography of both breast has craniocaudal and mediolateral oblique view. Yes. So craniocaudal. So this is the craniocaudal. You can see this is two view. One is cranio means above and caudal means lower. So above and lower view. This is called craniocaudal view. And this is the mediolateral view. Okay. So mediolateral view and craniocaudal view. Okay. So I think it will be more understandable. So mention a hypodense lesion with irregular margin is seen in the upper and outer quadrant of the right breast here. Hyperdense. So write 4 indications performing suspected breast lump before going to breast conservative surgery. Mammography is necessary and is gold standard. And for screening of high risk patient to diagnose occult carcinoma of the opposite breast. So if there is any occult carcinoma in the opposite breast present or not, and before any FNC, before going for surgery, before making a decision for breast conservative or radical mastectomy. So this test is very vulnerable, very important, I think. What will be the standard treatment? Breast conservative surgery and radiotherapy and sentinel lymph node biopsy, the SLNB. So breast conservative surgery, sentinel lymph node biopsy, and also the radiotherapy. If biopsy result positive in that case, for malignancy, so in that case we will go for axillary dissection. So facility, so where it will be done, where in the radiology department. So facility of radiotherapy, and there should be a facility of frozen section biopsy. So to view craniocaudal and mediolateral view, so 4 radiological finding features here. Mass effect, you can see this is the mass effect. There should be another things, mass. Architectural deterioration, so you can see this is the normal and this is the abnormal. So architectural deterioration happens, and the symmetry of the breast symmetry will be lost, and the speculation You can see this is the speculation, speculum. This is speculation here. So these are the speculations. Okay, Packard area. A branching of calcifications. Here the whitish area, those are branching or connected with each other. So these are the branching calcifications. And clustering. Here it is a cluster. This is a cluster. Okay. You can see them clustering here. And microcalcification all through the Packard area. Small calcifications all around the breast. Here the calcifications. Okay. Whitish point out lesions. Name 5 disadvantages. Radiation risk. This is radiation dependent test. So radiation risk has always anxiety, that is radiation sickness, psychological and physical morbidity will be more expensive, and false assurance. So sometimes falsely detected. So mammograph X-ray, two views are taken. These are the craniocaudal medial lateral oblique views, compressed before taking the mesh. Okay. Features the magnetic speculated soft tissue masses. Here it is speculated soft tissue mass. Here, a linear branching of the microcalcifications. Linear branching of microcalcifications. And distortion of the soft tissue architecture. And candidate multifocal lesions in the same breast, lesions in the other breast which may not be apparent clinically. Here this is the CT scan. This CT scan taken from Verilab's Verilab book, I think. You can see colorectal liver metastasis completed tomography scan. Here you can see there are some multiple black area in the liver. This is the liver area. So this is the metastatic malignancy. Okay. So CT scan of the abdomen with multiple axial view. You can see multiple axial views showing multiple hypodense area in the liver and colon. Colorectal liver metastasis, write down the common clinical presentation. So, localized pain and tenderness and ascites. What are the common sites of primary malignancy? Gastrointestinal tract, breast, lung, liver, ovary, kidney, and skin. Name 2 investigations indicated such case, and ultrasonography and MRI. So you can see the computed tomography shows the air fluid level rim enhancement in the intravenous consists typical liver abscess. Here you can see this is the abscess, and it has a air fluid level. That is the air, it is the fluid level. So, air fluid level present in the rim enhancement, a sac-like structure within, and it has wall, and present in occupied lesion, space occupied rim-like enhanced lesion present in the liver. So liver abscess. And the component scan of the patient, a liver tumor at the right lobe of the liver using intravenous contrast enhancement. So this is a contrast imaging, CT showing there is a lesion in the right lobe of the liver here. So it is I think space occupied lesion or metastatic carcinoma or the hepatocellular carcinoma here. And now this is your quiz. What is the film? I think you know this is more like MRI or 3D specific, system specific interest, right? This is a MRCP, magnetic resonance of cholangiopancreaticogram. So this is called the MRCP. So by this test, it is specific for hepatobiliary system, and you just see the hepatobiliary channels. This is the intrahepatic channels. This is the right side and left side duct, and this is the bile duct. Okay, you can see there is a stone in the black stone in the whitish luminal structures, a huge area. So this is the stone, and you can see here the stone in the this region, that is common bile duct, and this is the pancreatic duct, and this is the bile duct, reunited from what? Ampulla of Vater. A stone is impacted in the ampulla of Vater. That's why dye cannot pass through it. So this is the stone. Another stone is present in the CVD. And you can see this is the congenital anomalies, that is biliary atresia. You can see percutaneous drainage of the percutaneous dye injected, and here this is stricture, biliary stricture or atresia in case of children. Here you can see there is a confluence, there is a tumor enhancing the confluence of the right and left tract, and there is also narrowing of the CBD. And you can see in this picture the CBD is hugely dilated because there is something here in the stone or stricture, TB, tuberculosis, and worm. And you can see here this is this main pancreatic duct and multiple stricture and inflammatory exudates present in surrounding area. And here in this here you can see there is stone obstructed in the bile duct just proximal to the common main pancreatic duct. You can see a radio opaque radiolucent area which shows a stone or black area, so the dye cannot pass through here. This is also the black area, this is also black area, this is also black area or stenos or atresia, and also you can see the black area also can causes cholelithiasis. Here the MRCP report how it is being explained. So gallbladder is demonstrated normal hyper intense signal form lumen with no evidence of interluminal signal void. Sometimes stone can be seen within the gallbladder. Gallbladder stone associated with cholelithiasis. So stone is radiolucent and whole channel will be radio opaque due to dye. So anywhere when you can see any black shadow, that may be in the pancreatic duct or maybe in the biliary duct, extra or intrahepatic biliary channel, it is a stone or any foreign body. Okay, CBD is normal, and the coarse caliber and outline, you can see, you must explain the coarse caliber and outline of the CBD, and the GB wall thickened 4 mm, and 60 duct and confluence CHD appears normal, multiple GB calculus. Seen visualized pancreatic duct appears normally in coarse caliber and outline with no evidence of interluminal signal void. So signal void means radio opaque. So signal void, interluminal signal void or side duct dilated. So you can see that is how a MRCP report is done, because you must mention the from where the intraluminal signal void comes through. You must find out where is the signal void, where is the black area, where in the white use in the huge here where you can see this is the black area. So this is the intraluminal signal void. So you must explain where you are seeing any lesion. Okay. So this is the interluminal signal void. This is the interluminal black signal void or multiple signal void. Single signal void. You have to mention like this, because in the MRCP film detections, your teacher will try to know either you find out the stone, or you just find you can explain about the signal void from the lesion, right? So this is the important things you should mention in your exam. So thank you very much for try this kind of videos. For I know it is a long video, but I think I just did some homework about this, and I think this is all you should know in your OSPE exam and also the viva exam. I think it will be enough for you to complete the session. And there are a lot of x-rays can be taken from different situations of a patient's profile, but that is uncertain. But these x-rays are the basic x-rays you will see in your exam, and I think you can explain, you can read the x-ray read the and also try to answer the questions. And also MRI and MRCP, those are advanced in case of MCPS and FCPS part 2 exam, and they will try to hammer you and try to know your maturity by keeping you in different situations. So that is all I try to explain here. But yes, there are a lot of MRI, there is a lot of MRCP film available, and also CT film available in your day-to-day daily practice. Also, where you are training nowadays and your training ground, you can see a lot of patients coming each and every day, and try to see the reports and free films in daily purpose. And after that, you will be very expert on it. I think you have to see a lot of X-ray, a lot of MRCP and CT and MRI to have some knowledge, or it will be smooth for diagnosis of different hepatobiliary disease, and also intra-abdominal malignancies, primary relations, secondary relations, dilatations. So in many things you will diagnose after seeing a lot of X-ray and MRI film also. Thank you very much for keep listening to my videos. So in the next time you will see some long case, short case videos, and also some surgical specimen related topic, and also and their tutorials also. Thank you very much for your kind attentions. Keep like and subscribe my channels, and it will give me much encouragement regarding your topic. Thank you.